My name is Albert Arslan. I'm one of the DMC Primary Care Sports Medicine graduates. It's good to see and good to be with everyone again. So thank you for the privilege of letting me lecture with you guys on your Wednesday didactics. I currently work at Tria Orthopedics out in the Twin Cities in Minnesota. I was asked to give this lecture actually earlier this year as part of a value-based care symposium. A lot of this is an initiative by the government to really kind of transition from like fee-for-service models to more value-based care. So instead of just having physicians be reimbursed for all the things we do to patients, ordering tests, ordering prescriptions, it's really more kind of focused towards transitioning towards patient outcomes. And making sure that they're actually getting healthier as a consequence of all the things we do to and with them. The facet that they asked me to talk about was diagnostics and specific about imaging and x-rays. So the title of the talk is When to Get an X-ray, When to Reassure, and When to Refer. This is a little bit about myself. Went to University of Buffalo for medical school. I'm emergency medicine trained out in New York City. And as I just said, I did sports medicine at Detroit Medical Center. So objectives of this talk is really kind of just understanding the principles of value-based imaging, value-based care, identifying red flags for imaging and referrals, when to apply some of the tools in our tool belts and using really that specifically geared towards decision rules. Kind of learning how to provide reassurance to patients and strategies, word choice, like what we say to patients, kind of suggestions to be helpful to kind of help navigate patients through our visits and our encounters, and just really knowing overall when to provide orthopedic referrals and when it's really mostly appropriate. I was allowed to do one joke. This is the joke that I put in. It's really a bit of a jab at my emergency medicine colleagues that we often kind of are overly reliant on our diagnostics, our tools, our imaging, our CT scanners. So instead of doing the basic things, speaking to a patient, examining a patient, understanding the patient, we're kind of more prone to kind of just be heavily reliant on diagnostic tools and CT scans. So it's a funny, lighthearted way of just saying, let's use our hats more than our tools, or our brains more so than our tools, rather. So value is kind of conceptualized as this equation, outcomes over cost, right? So if we want to increase value, we want to increase our patient outcomes while having an inverse relationship to the cost in order to increase those outcomes, right? And more imaging does not necessarily lead to better outcomes as well, right? So this JAMA article talked about how an estimated 30% of imaging that we use is really probably unnecessary, right? And that's a huge financial burden on the medical care system, right? And the risks of these things aren't just financial, right? And the costs, there's incidental findings, which or really kind of expose patients to other harmful testing down the line, radiation, which really shouldn't be kind of poo-pooed, and overdiagnosis, where we really don't want to be giving patients things that we really can't take action on and really doesn't really help the patient's overall global health. Right. So average cost of a plain film in the United States can be anywhere between $50 to $150. So potential annual savings by eliminating 30% of these unnecessary tests could be anywhere between 2 to 15 grand per year. Right. Just multiply that out per all the physicians practicing. That's millions, tens of millions of dollars annually. So a pretty substantial sum. Radiation exposure. I really like this slide. It talks about the different types of x-rays and CT scans that are performed, and the different amount of radiation that we expose patients to. We're probably already aware of the unit of measure is a millisievert. So a millisievert of radiation will expose a patient to a 0.005% lifetime fatal cancer risk. And this is cumulative, right? So I put this picture of Minnesota snow over here to remind us that you just don't kind of get one x-ray and then that radiation wears off. We have all these additive x-rays that we do, and you keep doing an x-ray, you keep adding risk to the patient. So an example of a chest x-ray, something that's probably more common in the emergency department than it is in a sports medicine clinic, but a pretty common test is 0.02 millisieverts. A lumbar spine x-ray, 1.5 millisieverts, right? A CT scan can be anywhere between 2 to 8 millisieverts. So these are decent amounts of radiation. Okay. So just as a reminder from that joke that I had put on earlier, to always think about doing the clinical first and imaging second. So speak, examine, understand what you're doing with the patient, and use your tools to confirm your diagnosis, to confirm what going on. Don't use your tools as a fishing test. I'm not really sure. Let's just kind of get an x-ray. Let's get an MRI. Let's kind of just see what shows up. Is I don't really know what the patient's telling me, and this exam kind of just didn't make sense, right? It's kind of a little bit more important for us to kind of put the puzzle pieces together. So when to get an x-ray. So kind of no-brainer things, right? Suspected fractures, dislocations. You've got a good story, right? You've got a high energy mechanism. A patient has difficulty bearing weight. We see obvious and gross deformity, or the patient has focal bony tenderness. Right, like a common thing that I probably encounter now with our rotating residents through our orthopedic injury clinic is oftentimes they'll just kind of want to get an x-ray without really justifying it. They'll have a pretty reliable physical exam where it's really kind of ligamentous tenderness. There's really no bony tenderness. The patient is able to bear weight, but they kind of just want to still get the x-ray. And really everything I just said sounds reassuring. So if we kind of communicate why we're not as worried about that to the patients, a lot of times patients are okay foregoing x-rays, not all the time, but a lot of time, as long as they see that you're kind of using your brain, they're okay with understanding and kind of avoiding things that they think and you think are unnecessary. Other times to get x-rays, suspicion of malignancy, right? Infective and inflammatory arthropathies, right? It's good to just make sure that there's no obvious destructive lesions going on in the bones, or that the arthropathies themselves aren't destructive, and you kind of want to gauge that. That'd be a good reason to justify getting an x-ray. Right. And then pediatric considerations are a little bit more vulnerable population. You know, growth plate tenderness, we really want to be mindful that, you know, when patients are skeletally immature, missing a fracture could have longer term consequences, and we want to be mindful of that. Refusing to bear weight, that would be a good reason. It's pretty not typical for a walking child, a previously walking child. I'd probably want to err on the side of being cautious and get an x-ray for a patient like that. Then obviously concerns of non-accidental trauma, child abuse, right? Those things are super important to be cognizant of. And I'm not necessarily saying we should definitely err towards getting more x-rays in this population of patients. You could very well have just a really good plan where, you know, you say to mom, you say to dad, like, hey, I'm not really sure, but I think that we have a lot more things under the reassuring column than the not reassuring column. Let's have a good follow-up plan. Let's just say come back in 7 to 10 days, right? Oftentimes fractures can declare themselves in 7 to 10 days, if not present on a repeat or on the initial plain films. Come back in a week. We'll re-examine Timmy. We'll see how he's doing, see if he's walking, see if he's feeling better. Then we'll consider doing an x-ray at that time if things just aren't adding up. And most of the time, patients are okay with that because everyone wants to avoid unnecessary radiation to our younger population here. Okay. Probably one of the two most common things I'd probably say that we see in our urgent care are really low back pain complaints and shoulder complaints, right? So low back pain complaints, when we're going to get plain film radiographs, we really should have good reasons to get those radiographs or advanced imaging like an MRI, right? If there's a history of malignancy, prostate cancer, you worry about blastic lesions going to a spine, you might be able to justify getting an x-ray. Most of the time, we'll probably err on the side of getting an MRI for those patients. Red flag symptoms, B symptoms, night pain, weight loss, systemic constitutional symptoms, fevers, night sweats. Those are probably good reasons to consider doing advanced imaging. We worry about things like spinal epidural abscesses in patients with certain risk factors, substance use disorders, substance dependence, cancer histories. Right, neurological deficits is a big deal. We want to make sure that there's no motor deficits not attributable to pain. That would be a good reason to justify getting imaging of the spine. Trauma can be a little bit trickier. You know, kind of depends oftentimes how patients interpret what trauma is. You know, back pain can be very debilitating. It can really very much affect their ADLs. But oftentimes patients come in with atraumatic, non-traumatic back discomfort, and you have to really walk the patient through understanding why x-rays of the bones and of the joints aren't necessarily going to be helpful specifically for low back pain. But there are exceptions to that rule. I would probably say that our elderly population, those who suffer with osteoporosis and osteopenia, right? I'm often very surprised how often many of them come in with low energy mechanisms or really like not crazy stories, and they end up having compression fractures, right? And you identify these on plain films. So, you know, kind of just be extra cautious with those risk factors. Okay. Shoulder pain is another one. I'd probably say that it's that in one of those initial slides I was referring to and talking about trauma, deformity, weakness. fractures, definitely dislocations. That would be reasons to kind of justify getting an x-ray. But things like rotator cuff pain without trauma, no red flag symptoms, patients having good full range of motion. Oftentimes, an x-ray is really not going to add much to the patient's clinical picture, right? This is a soft tissue, a tenderness, a muscular problem. X-ray is not going to really say, hey, like this is going to change management for us. I think you're going to do well with physical therapy. You just need some time. You need some eccentric strengthening exercises, plus or minus doing a steroid injection for symptoms, right? But the x-ray is really not going to add much to it. Okay. And then when we think about referring these patients, it's weakness post-injury or failed conservative therapy. That's oftentimes when I would think to refer patients for shoulder pain that's just not getting better with conservative care. Right, it's a really good resource, the Rational Clinical Exam. This is super awesome. It goes through every single exam maneuver that you could think of, and it talks about sensitivities, specificities, likelihood ratios. It talks about the limitations of each physical exam. I'd highly recommend this. It is a pretty powerful PDF and online resource. Last I checked, I forget if there was a paywall or not, but when I was a resident, it was available to everyone, and hopefully it still is available to everybody. But this is a pretty useful test to understand when to use a physical exam, why it's good, and why it has limitations. Right. But let's often not forget that our individual exam maneuvers do have limitations, right? And like a good example, I would say, is the McMurray test as an example, right? The sensitivity of a McMurray test can be anywhere around 50%, right? And then joint line tenderness, and that's for a meniscal injury, right? Joint line tenderness can have a sensitivity of around 80%. So, you don't use these tests in isolation, right? They're meaningless if they're used in isolation, if you're just using one instrument at a time. They're really useful if we're using them in concert with one another, right? You have a history. Asking questions is a test that have sensitivities and specificities. Every question we're asking is an individual test. Are they opting in? Are they opting out with the questions that we're asking? Each physical exam maneuver is a test. And then together, the composite examination really synergizes the diagnostic accuracy of our history and physical exam together, right? You could really get a specificity after getting a good history and physical exam for a meniscal injury around anywhere between 80 to 90%. So the test individually, not so great. The tests together in unison in concert, pretty decent, pretty powerful. All right, so when to reassure patients. So reassurance, I would say, is oftentimes, we think about minor sprains, no red flag symptoms, right? Able to bear weight, improving symptoms, normal function range of motion tests, right? That's when I would say that's when we're going to reassure our patients. And then we should also set expectations for our patients. I would say that when I first started practicing, one of the mistakes I would be making is that I didn't say things like, oh, for this, maybe we should give this 2 to 3 weeks or 4 to 6 weeks before we worry about a lack of improvement. Then we think about chasing more advanced diagnostic images. So I think patients appreciate those kind of bookends, those timeframes, those windows, so that they understand that what they're going through is a normal experience, and that they really shouldn't rush to think that 2 sessions of physical therapy is going to improve what they're feeling. I would say that, giving those windows are super helpful for them, and also providing written aftercare instructions can be helpful and act as a safety net for them as well too. Right, so decision rules, Ottawa ankle rule. This is an excellent tool. We're taught this ad nauseum in the emergency department, right? What I would say, what I would really caution is to really be aware of what the inclusion criteria are for these things. I have the inclusion criteria on the next slide over here, right? So adults over 18, new injuries less than 10 days, right? And then you worry about any sort of clinically significant fracture that is basically more than 3 millimeters, not an avulsion. So, why those inclusion criteria is important is just because oftentimes I'll use the metaphor of the Canadian head CT rules. Oftentimes in the emergency department, patients, or rather residents, will present the patients to me. They'll say things like, oh yeah, this patient had this type of mechanism. I'm going to really use the Canadian head CT rules to justify not using or getting a CT scan for this patient's head trauma. But oftentimes what the residents forget is that Canadian head CT rules require the patient to have lost consciousness. So most of the patients that come to the emergency department don't often lose consciousness. So you can't really apply the Canadian head CT rules to those patients. So it gets a little bit trickier in those circumstances. So that's And that's what the studies really looked at. They looked at patients who lost consciousness in that subset of patients. So I just remind you to use that same understanding when using your decision rules to understand what these studies looked at and what their inclusion exclusion criteria was for their populations. Okay, auto and knee rule. This is just talking about the inclusion criteria again, right? Over 18 years old, blunt trauma, injury less than a week old, right? They have the five rules over here. So age over 55, patellar tenderness, fibular head tenderness, and ability to flex 90 degrees, and ability to bear weight. A lot of these can be really intuitive if you think about what Ottawa is trying to achieve here, and pretty good sensitivity, right? 100% specificity, 54%, right? And then they had validation rules for pediatric studies, which were pretty good as well. Test variant powered pretty similarly to the adult population. All right. Pittsburgh, I don't really often use this too much. They're pretty bare bones. Blunt trauma, age cutoffs, and inability to bear weight. Again, this is pretty intuitive. I don't often have to really look these up. It's just more kind of makes sense when you understand why they're doing this. So some kind of language tools to offer the patients who are really kind of anxious and need a little bit more guidance or hand holding, normalize what the patient is saying and their experience, right? Many people with back pain worry about serious causes, right? Based on your symptoms and exam, there's no warning signs that would suggest something dangerous. Most people in your situation recover well without the need for x-rays or scans, right? A lot of times in my clinic with atraumatic back pain, in the absence of red flags, they'll say things like, hey, 90% of patients improve in 6 weeks, which is good and bad, right? It's good because it'll resolve, but it takes 6 weeks. And oftentimes they really understand after I use a spine model and explain to them why we get MRIs and what we do with those MRIs, they tend to be pretty receptive to that, right? Provide clear evidence-based rationale. So medical studies show people with symptoms like yours, x-rays don't really help and speed up recovery. And oftentimes unnecessary imaging can lead to false alarms, more tests, unnecessary treatments, right? So evidence-based using Ottawa ankle, Ottawa knee, Pittsburgh knee, patients can sometimes be pretty receptive to that, right? Discuss risks of unnecessary imaging, right? We talked about radiation earlier, and I think this is pretty powerful when it comes to our pediatric population. Well, generally, I think 90% of the time, anecdotally, I would say parents are on board with this. We advocate for watchful waiting. I think this is our best tool in the clinic, right? Hey, we're going to monitor your symptoms. If it's not getting better, we definitely can think about an x-ray. We definitely can think about advanced imaging, maybe in the form of an MRI at a future time, right? It's always a parachute for us. So I don't want you to leave this clinic worrying about that. It's on the table. It's on the shelf. Just let's start this type of management, this therapy first, and then we could always circle back to it if we're not getting better. Right. And then always invite questions and have shared decision making, right? Always say to the patient, I want you to be the captain of the ship. I want you to feel comfortable with this plan. If there's anything you protest, let me know. We could talk through it. If you feel super strongly about it, we could figure out how to justify doing something together. And lots of times patients will be receptive to that too, right? So imaging pitfalls for the primary care clinicians, right? Ordering just in case, radiographs for chronic, non-traumatic pain without exam findings, right? The osteoarthritic patient didn't have trauma, seems like pain that's consistent with their previous osteoarthritis pain, probably don't need to repeat imaging for that. And obviously to getting imaging or not getting imaging without a follow-up plan, right? It's important for patients to understand what their goals of care are and what timeframes are and what their aftercare instructions are. All those things are important to a complete patient care visit. So when to refer these patients, these two are pretty intuitive as well, right? So urgent referrals, things like open fractures, dislocations that you cannot reduce yourself, neurovascular compromise, right? You always check for a pulse. First thing you do when you see dislocation or fracture, check for a pulse, right? Suspected septic joints or malignancies, you'd probably want to refer those to the emergency departments. Those are the more urgent referrals. Right, routine referrals are things like failure of conservative therapy. You're not really sure what the diagnosis is even after your full evaluation. Or you do get imaging ultimately, and it does show something that would be surgical, like a full thickness rotator cuff tear, or patient having mechanical symptoms with a loose body seen on an MRI. That'd be a good reason to refer the patients, our surgical colleagues. Okay. Case studies, these are just pretty good softball questions. You have a 34-year-old in your clinic, 2 weeks of atraumatic low back pain after lifting at work. No red flag symptoms, normal physical exam, no concerning cancer history, just paraspinal muscular tenderness, right? Do we get imaging in this patient? No, we don't get an x-ray on this patient, right? Early imaging is going to be pretty non-specific for them. It's not really going to be meaningful to them. It's really just going to be management with physical therapy plus or minus non-steroidals and follow-up in 4 to 6 weeks. Right. 27-year-old, 6 months of insidious onset low back pain starting 6 years ago. Worse at nighttime, right? Early morning pain more than 60 minutes. Alternating pain between buttock, right? Already did failed trial of NSAID management. Labs are otherwise remarkable. No other red flags, but what would you want to do with this patient? You'd probably want to refer this patient to rheumatology, right? Axial spondyloarthropathy, right? This is someone who's probably going to be HLA-B27, sacroiliitis. This is someone that would benefit from rheumatologic care. All right, this is a nice little summary of everything. We kind of talked about high yield points, when to get x-rays, when to reassure, when to refer. So, the high impact trauma patient, probably want to get, x-rays on that. Minor sprain, normal range of motion, reassurance would be good. Red flag symptoms, you want to get x-rays, you want to get imaging, you're probably going to want to refer this patient. So, the rest makes sense. So practical takeaways: use validated rules, avoid imaging in low risk situations, provide reassurance to patients with a good follow-up plan, and then refer when the care is really beyond your scope or it fails to improve. So resources for the primary care guys, right? I'm sure Dr. Keikos has mentioned this book. This is a very extremely helpful book. MD Calc has all of our scoring tools and calculators. The Choosing Wisely campaign, super helpful, in addition to the Rational Clinical Exam. This is an example from the Choosing Wisely where it talks about the different tests, similar to that chart earlier, talking about all the different types of x-rays and millisievert x-ray exposure, and typically when it's appropriate to do something contingent upon what your clinical suspicion is. So that's a pretty helpful resource for us too. Okay, and these are my resources. Thank you all very much.
Yeah, nice job, Al. That was well done, nice and succinct, and you really hit a lot of the salient points there when we're deciding on when to get X-rays. That millisievert chart, I think, obviously we don't want to instill fear in our patients, but it's still a good reminder for us. And even for me personally, right? Sometimes you're tracking X-rays. We're so worried for fractures, let's just say, and you're so worried about this fracture potentially, displacing or changing, and then you end up getting a couple X-rays throughout the course. And there's more studies now showing that sometimes even frequent X-rays can slow down healing, and there's reports of that too. So always being mindful of that, but understanding that their utility. But I think the goal, you can correct me if I'm wrong, but I think it's 50 a year. You don't want more than 50 millisievers a year.
Yeah, that's what I've been told as well.
Yeah, so 50 is.
Never looked that up though. That's just what I've heard in training.
Yeah, no, I believe 50 is that number, and obviously you can see getting a CAT scan here, getting a couple X-rays here. You're not going to be way below that threshold. So I don't want you to be overly fearful. Every time you fly, I can't remember how much radiation you get just from flying, but it's going to be up there too. So if you're making a lot of trips and cross country or even overseas trips, you're going to get relatively the equivalent there too. But just being mindful of it, especially as clinicians who order it. Sometimes we reflexively order these X-rays, and I think that's a mistake. So just being conscientious about it is smart. So I think the way you outlined it was well done. So I don't really have too much to add outside of that.
Thank you.
Any other kind of comments or questions for Al?
I guess my one question is, how do you, and we have all these tools and stuff, but from a liability standpoint, I know sometimes people have, obviously we have old lady comes in, minor low mechanism fall, most likely still going to get an x-ray of the low back if they're having back pain just throughout the fracture. But I think just in like the past few months, I have seen things where I'm just like, I don't think that would be a fracture. Then you get it back and there's like a small avulsion fracture. It might not change management, but how do you manage the liability standpoint of like, oh yeah, let's watch and wait. And then they do come back in a few weeks and you do the x-ray and there is a fracture that you could have managed a little bit differently.
Yeah, that's a great question. I think you get a lot more comfortable with that the more you practice. You inevitably accept that, litigation is just a part of what we do, and you'll never be able to control how, when, why, where you'll be sued. It simply will highly likely happen. The best advice I think I could give is just make sure what you're doing makes sense, right? You're never going to bat 1,000, but if you're going to like say things like patient had a fall, no bony tenderness, patient is able to ambulate, no red flag features. We'll have patient come back in a week. That's a plan that makes sense, right? And that's a completely defendable type of medicine to practice, right? Don't practice defensive medicine, practice defendable medicine. So everything that you just said in that little epithet, that's what's going to be a reasonable thing. And lawyers, courts, judges, they understand that, right? They understand that you see 40 patients in a day, that you see a lot of the same thing over and over again. If you're providing the same care to each of the patients and your plan makes sense, I really wouldn't worry about that. Plus, when you explain to patients things like, hey, oftentimes first x-rays don't really show fractures. We could really see it at 7 to 10 days, and you document that and they come back. That's also part of that defendable type of medicine to practice.
Yeah, I agree. That was a great response. Great response. So
I need you to go now so you make it.
okay. Sorry about that. Matt, I think you're up next, unless anyone else had comments for Al. All right, Al, thanks for giving that lecture. We're going to expect you with an encore performance next year.
Looking forward to it. Thanks, everybody.
I'm Matt. I'm one of the primary care sports fellows. So this topic today I'm going to give, it's going to be on fractures in sports. So obviously 30 minutes is not enough time to cover, every type of fracture that there is. So I'm going to try to talk about some topics, some different general groups, and we'll kind of go through there. Some of this might seem similar to my presentation last month, which was on the pediatric patient. So some overlapping concepts here. So starting off, why do we care about fractures in sports? So they're estimated to be about 10% of all high school sports injuries. And, this can be significant missed time to our athletes. Most of the kids, they want to be out there, they want to be participating. They don't want to have these restrictions, and it could lead to some serious interventions, including some surgical procedures. So Swenson et al. In 2013, they did a meta review that just analyzed the epidemiology of fractures in our high school athletes, and this was in the early 2010s. Our boys were the highest rates of fractures at 79.1%, and that included when they cross-compared our gender comparable sports like women's soccer versus boys soccer. The fracture rate is about 1.82 per 10,000 athlete exposures, which we defined as a practice or a game. And then our highest rates were in our what would assume to be our culprit sports. So our high contact sports, our football, our boys ice hockey, and our boys lacrosse. The most common mechanism at that time is going to be a contact with another player. That was almost about half of our fractures. A smaller percentage of these went on to require surgery. So 17.2% required a fixation. And the most common sites were actually going to be in our hands and our fingers, and then our lower leg at 10% and the wrist at 9.5%. So keeping that in mind, good to know what these might be coming in with. So since we started at 32% in hand and fingers, I'm going to move on to metacarpal fractures. When we talk about metacarpal fractures, they can be divided into the base, the shaft, the neck, and the head. Most of these are going to be stable and can be treated non-operatively with some buddy taping and some splinting, keeping them in extension there. The metacarpal neck fractures can be reduced, closed reduction with the JAST maneuver, and then we can immobilize after that. Now, if any of these fractures demonstrate displacement or malalignment or have significant angulation, they should undergo operative treatment. So for the primary care sports guys, this is what to keep in mind and what we should prefer. In general, anything greater than a 10 to 20 degree on the index finger should be sent for a surgical consultation, and then anything greater than 40 degrees on the smaller fingers. So always keep in mind, we use that index finger more often, so we need to keep a smaller angle there. This is the JAST maneuver for that reduction of these metatarsal neck fractures here. And then moving on to phalangeal fractures. So important to me as a former basketball guy. These occur pretty often in our ball sports. These can be divided again into base, shaft, and condylar fractures. The proximal and middle phalangeal shaft with minimal displacement and no interarticular involvement can be treated non-operatively with a plain cast. So these kids don't necessarily have to miss a lot of time as long as pain allows. And then fractures of the distal phalanx tend to be the most common, but we can get them in other phalanxes as well. The tough fractures, these are inherently stable. So when you think about, we have the nail plate dorsally and then the fibrous septa on the volar side that kind of helps stabilize these. These can just get managed with splinting. And then the mallet finger is going to be the lower picture here. And that is going to be a dorsal avulsion of that terminal extensor tendon insertion, as we can see it kind of breaking off here. And these are often seen with an axial force applied to the fingertip, causing that force flexion of the DIP joint from that extended position. So again, keep in mind this with our ball sports here. So that can be pretty common. And these get full-time extension splinting because these are usually pretty well and stable. Moving on to the interarticular fractures of our phalanx. These are going to be a little bit more concerning. So these are injuries into the PIP to DIP joints, again, common in our ball sports. Can be unicondylar, like the grade 1 on the left, or the grade 2 in the middle, which is a little bit more displaced, or they can be bicondylar, like the grade 3 on the right. When you start talking about the grade 2s and the grade 3s, a little more concern for instability, and these should get a surgical referral from the primary care side for operative fixation. Anytime we start talking about crossing into the joint space, we need to be concerned about the potential to progress to arthritis, especially in these small joints. Moving on into some of those pediatric applications, just talking about our physeal fractures. This is going to be into our Salter-Harris classification. So remember, we can use the Salter mnemonic to remember how these fractures present. So the type 1s, they're going to be they're straight across the S through the physis. The type 2s, they're going to be our A, that's going to go above the physis into the diaphysis or the metaphysis. And then the type 3s, those are going to be our lowers. So that's going to extend into the epiphysis through the joint, or not through the joint. And then type 4s are going to be to or through. So continuously through the epiphysis, the physis, and then the metaphysis. And then the type 5 is going to be kind of that crush of the growth plate itself. So this is important to distinguish, for the risk of growth disruption, and again, what needs surgical referral versus what we can manage in our non-operative clinic here. So just a quick refresher on the growth plate. 3 main zones that we need to talk about. So starting with the resting zone, this is going to be our quiet state, basically, chondrocytes that are kind of resting and waiting to help replenish and nurture the other zones in the area. They're going to be, again, those germinal layer cells that provide our stem cell base to help grow the cartilage and help grow the bone. The proliferative zone is going to be the next zone above. These are going to be our actual active chondrocytes. They help create that longitudinal bone length. So injuries here are going to be very concerning for disrupting our growth, causing a physeal bar. So that's why it's important to make sure we get the right classification here and have the right management. Injuries into the hypertrophic zone are going to be a little less concerning because these are already going to be terminally differentiated chondrocytes. So they've kind of reached that maximum potential there. And so that's why the 1s and the 2s don't concern us as much as the 3s, 4s, and 5s. Salter-Harris type 1. So on our x-ray here, we can see widening of the tibial growth plate here. I kept the images all with the distal tibia so that we can see the changes in the different types. For these, a lot of times we can manage these non-operatively as long as there's minimal displacement or we get good reduction under anesthesia. we want to make sure if we do get reduction that it's smaller than 3 millimeters of gapping, because if there is still greater, it might still need operative fixation in order to avoid that premature closure. And all these kids are going to need to be followed about 6 to 12 months to continue to monitor for growth arrest and make sure there's no angular deformity of the bone. The Salter-Harris type 2 fractures, they're the most common. Our management is pretty similar to the type 1 fractures. We can see it here on these two radiographs with this. I've put the little blue line to help people see it, is migrating up into the metaphysis here from the physis, away from our joint, which is important there. So most of these are going to be able to be non-displaced, and they're able to be managed non-operatively with close reduction and casting. But again, if there's greater than that 3 millimeters of displacement, we should get a surgical referral to make sure that they don't need fixation. Moving on to our Salter-Harris 3s, these are extending into that epiphysis. There's significant risk here, right? So we're moving towards that proliferative zone and into that resting zone. So we're starting to affect more of those stem cells. So we need to be concerned about the potential risk for growth arrest with this. Also, it can be extending into that joint space. So we need to worry about things that affect the joint, like joint stiffness, post-traumatic arthritis, and then and some angular deformities as well. So all of these should be sent to an orthopedic surgeon to have at least consideration for surgical fixation. So I probably wouldn't keep this one in the non-operative office. Again, these kids are going to need to be followed for 6 to 12 months to keep monitoring their bone length and the physis itself. For the Salter-Harris 4, so I kind of like to think of these as a combination of the 2s and the 3s. Again, passing through the metaphysis, then the physis, and then into the epiphysis. Again, we're getting through the proliferative and the resting zone. So again, concern for the premature physeal closure. We're into the joint, so we're worried about the stiffness and the premature arthritis. Kind of just like those Salter-Harris 3s. So these are going to need some ortho referrals as well. And then the Salter-Harris 5, I couldn't find a good picture for these, as these can be kind of radiographically occult. You might need to end up getting a CT to really analyze these. These are going to be kind of the erasure of that growth plate, so definitely need a concern for premature physeal closure. And these are going to need an operative referral as well. As we so part of that Salter-Harris classification moves forward into our transitional fractures. And these, again, are going to be fractures that are unique to this pediatric population. And it's during the period where the physis is having partial closure. So it doesn't close symmetrically at once. And it's most commonly seen in our weight-bearing distal tibia, but this can occur in the distal radius as well. So think about our tackling in sport, or those kind of sport athletes. Starting with the Talot fracture. So this is going to be a Salter 3 intra-articular fracture of the distal tibia. We can see it progressing here on this X-ray. It comes from kind of traumatic ankle injuries. So this happens because there's an avulsion of the anterior lateral tibial plafond by the AITFL. And it is going to cause kind of this separation here, this avulsion. The very rare fracture. It's going to be more common in our girl athletes. And like I said, this happens during that 12 to 15 year period, 12 to 15 year old period, while the distal tibia epiphysis is closing asymmetrically. So it's going to advance where the central aspect will close first, and then we'll move into the medial aspect. And then finally, the lateral aspect will close here. So that's why we're seeing this separation of the lateral aspect. It's a little bit weaker. Management-wise, these are going to follow kind of our displacement guidelines. So less than 2 millimeters out, we can, after close reduction, we can try a long leg cast for 3 to 4 weeks, which helps control that rotational component that contributed to our initial injury. And then after that, we can transition them into a short leg cast that they can walk in, or they can use a walking boot if it's going to be an older patient that you trust to take it a little bit easier on that side, and they might want to take the boot off for hygiene reasons. The majority of these are going to need operative management, so that can be called reduction in percutaneous pinning or the ORIFs there. The next transitional type of fracture we have is going to be the triplane fracture. So this is going to be a very complex Salter-Harris 4 with components in the axial, coronal, and sagittal planes. So these can be also difficult to totally see on plane graphs. You might need a CT scan too. Like our Charlot fractures, these are going to be present in our adolescents in that 12 to 15-year-old age group, often in very competitive athletes that are doing a supination external rotation event to their ankle. There's going to have very similar managements to our Charlot fractures. So less than 2 millimeters of displacement, they're going to be candidates for that close reduction and casting. It's going to be more ideal for more of a 2-part fracture than versus a 3 to 4-part fracture. And then we'll transition them into that long leg cast for 3 to 4 weeks with immobilization. And then they'll transition into the short leg for 2 to 4 weeks or a walking boot so they can start that ankle range of motion. And then again, anything greater than 2 millimeters is going to need surgery. And moving away from the Salter-Harris fractures, we're kind of staying at the physis there, so or the growth centers there. We'll have our avulsion fractures that happen at our apophysis. So this is definitely going to be pretty similar from my last lecture. And so when we talk about the pelvis, this is going to be a good area with our 7 different apophyses and our muscle attachments for where we're going to have these avulsion fractures. So this was a study in the Journal of Pediatric Orthopedics, a retrospective review of 719 fractures from January 2005 to July 2020. That showed most of these hip avulsion fractures are happening in our soccer players with their kicking and loading. The football players and then baseball players were the second and third there. The most common mechanism is going to be when we're loading to run, but you can see kicking doesn't fall too far behind. And then falls was going to come in third at 8.8%. Starting at the ischial attachment for the hamstring, these usually, this can be a good example here. I like this x-ray that you can see the capsule kind of coming off here. These patients usually feel like a pop that happens after with a sudden onset of pain, usually during that explosive activity, right? So our kicking or sprinting or jumping. These patients have pretty severe tenderness at that ischial tuberosity. Now, it's always a good thing to compare contralaterally, right? Because that's usually just a tender spot to begin with. So that's why we have 2, right, to compare. And then they're going to have that weakness in knee flexion, right? We're losing that proximal hamstring attachment. And if you passively stretch them at the hip, they're going to have increased pain as well. If you're not seeing this nice x-ray finding, we can go ahead and get an MRI. That's going to show some avulsed piece here as well with our hyperechoic bony edema here too, or our hyperechoic effusion here around the site of fracture. So when in doubt, we can always get an MRI if they're not progressing as expected. The next site on our hip is going to be our AS-IS apophyseal avulsion. This is going to be the contraction of that sartorius and the TFL. These are usually going to be our male patients. They're going to have that. That's going to be our some hip flexure and knee extension, and then the radiographs usually see a good bony displacement. So we're seeing it here compared to this other side here. You can get further imaging if you need to confirm your diagnosis, but hopefully it should be apparent there. Our next fracture is going to be our AIIS apophyseal avulsion fracture. This is going to be our rectus femoris attachment. Usually happens as that hip extends and the knee is flexed, shortening on that tendon. Most common age is going to be males, 14 to 17, are kicking sports. So again, soccer is going to be a big culprit here. And then on physical exam, we're going to have anterior hip tenderness, ecchymosis, and weakness in hip flexion. This radiograph, it's a little bit more subtle, kind of like that ischial tuberosity, but we can see it when we compare to the left side. The piece there is clearly avulsed off that ASIS, or the AIIS, I'm sorry. Most of these together are going to do well with non-operative management. Again, better outcomes if these are caught early, and we usually want to try to identify them within 1 month after their injury. And then we could consider operative fixation for fractures that have displacement greater than 2 centimeters and large fragments. And the other thing is to continue to monitor their progress, right? So if they're not getting back to the field, they're still having prolonged pain, or they're starting to have non-union on X-ray, we should get them over to our surgical colleagues. Moving on into another smaller subset of sports fractures, we're going to have our bony stress injuries. So these injuries occur mainly as a response to repeated mechanical loading. We're going to see that these normally happen in our weight-bearing areas. There was a study that showed there's a higher incidence actually in military recruits than our athletes. So 3.2 to 5.7 per 1,000 person years versus 1.5 to 5.7. And then we're seeing an increase in this in our pediatric athletes as well, probably due to that increase in the sport specialization, right? We're doing baseball year round, we're doing soccer year round, we're doing basketball year round. They're not resting a lot of these joints or changing their motions. So the risk is going to be higher in those athletes that do higher impact sports and repetitive loads, cross country, running, gymnastics, basketball, track. And when we talk about our almost like our lay population, but the general population, the risk is going to be lower than in athletes and our military personnel. But anytime a patient comes in and has pain in a like bony pain, and they just started a new like intense unaccustomed exercise, it should be kind of in our differential there. So always have it in the back of your mind. And this is going to be from Nature. They did the incidence of these bony stress injuries in our college athletes. You can see one main thing that sticks out a lot, higher rates in our female athletes. But you can see that it kind of bears out with the cross country and then track and basketball. So these high repetitive loads on the lower extremity tend to lead to more bony stress injuries. This is going to be the kind of the pathophysiology, but really the one thing to really remember with the stress injuries, it's basically the idea that this micro damage continues to outpace the ability of the bone to finish its remodeling process. So when we think about it, the bony micro damage causes cracks and then apoptosis of our bony cells, which should cause some increased bone formation, but we might get instead we're getting bone resorption and leading to further damage formation. So if we don't rest and we don't stop this cycle, you can see that this continues to progress into a true fracture outside of just like a stress injury. When we're diagnosing these patients, we are noticing really history and physical exam is going to be the most important thing, and we're going to use our imaging here. So kind of good takeaways from our first lecture here about how many x-rays do we really need. So this pain is going to be kind of a good range from mild to severe to when you're finding them, where it's at. And really, we're going to look for that localized bony tenderness that gets aggravated with loading. There may be local swelling and erythema at the more superficial sites, so like your metatarsals in your foot. But for your deeper sites, like your femur, you might start to notice these symptoms a little bit more vague, a little bit harder to identify. Imaging finding, on x-rays, we might be getting that dreaded black fracture line, but usually we're going to be seeing some periosteal callus, maybe some sclerosis or some thickening. And then on the MRI, we're going to get some bony edema like this top right image here. And then with on the corresponding side and the T2, we'll end up getting the hypo intense signal. So kind of the opposite as the T1. Or the T2 is going to be hyper intense, T1 is going to be hypo intense. With the for our management of these, it's going to be kind of guided by the location and the patient itself. So these high risk sites can be prone to delayed non-union, non-healing, or refracture, and that's going to be our fifth metatarsal, the sesamoid, the hallux sesamoid, the talus, the medial mal, the tarsonavicular, the tibia, the patella, and the femoral neck. And then those are really going to be kind of some of our poor blood flow sites. And then the management, really this comes down to activity restriction and modification. So you don't always have to make these patients non-weight bearing, but some of them, if they can't really tolerate their daily activities, that might be your first step, and then slowly progress them. Pain management, we try to avoid NSAIDs best we can. And as we talked about with earlier in that graph, we saw that a lot of these are female patients, but even our male patients are at risk for RED-S, the relative energy deficiency in sport. So we need to screen for that. We need to screen for eating disorders, make sure they're eating a well-balanced diet, getting all of their nutritional goals. And you could even consider a vitamin D supplementation, even especially here in Michigan, where we're not getting enough vitamin D through the sun. So again, most of these patients can start gradual return to their activity, is like light jogging and activity after a few days of pain-free ADLs. But in the high-risk cases, we might want to wait until we're seeing bone healing on imaging. And at all stages, the number one thing is that these patients have to be pain-free during and after their activity. And if they don't, we need to take a step back and delay them a little bit further, go back to the step that we were at prior. You can discuss with them if they're really itching to get into cardio again, or they're an elite level athlete that's trying to get back as soon as possible, and they don't want to lose that cardio fitness. You might want to switch to a lower impacts cardio training like cycling or swimming as they kind of rehab before they get back to that sport specific activity. This is just a quick graph about how you can kind of progress these patients through their treatment. Again, remember, the number one thing is, are they pain-free at this activity? Are they pain-free at their activities of daily living? And then you can kind of see how you kind of slowly progress. We're walking first. Okay, now we'll add on some jogging for a few minutes. Once we get through jogging, we can add on a full-on run. And eventually we're getting back to this sport. So, but we can see where this is, this could be almost like 3-4 weeks. That's significant time away from sport for some of these athletes that they're not going to be too happy about that. I think the stress fractures are a good place to transition into the fifth metatarsal, because it's going to give us an opportunity to look at kind of all three types of fractures that we talked about today. The fifth metatarsal, the base can be broken into three zones: the tuberosity, the zone 1, the tuberosity. Zone 2 is going to be that metaphyseal diaphyseal junction. And then zone 3 is going to be that aphyseal area within 1.5 centimeters of the tuberosity. And we can see that they all have their own type of fracture that aligns here. And then as we progress further, we can also get a spiral fracture of the distal metaphysis that leads to our dancer's fractures for anybody that's interested in performance medicine. Starting with the avulsion fracture. So just like our hip avulsions, this is going to be a sudden pull by the tendon on the base of the fifth metatarsal. So it's going to be the peroneus brevis tendon or the lateral band of the plantar fascia that usually happens after an inversion of the foot. It's going to occur at the proximal tuberosity, which is pretty distinctive in the anatomy compared to the Jones fracture. Usually happens in the setting of sports or trauma. They're going to have tenderness on exam, and they're going to have pain with resisted foot eversion as you're activating that peroneus brevis tendon. Here on the radiograph, we can see that this fracture is nice in our zone 1. It's at the tuberosity. It's not further up towards the shaft. And we can treat these non-operatively as long as there's no rotational displacement in a cam boot or a stiff-toed shoe. And we're usually going to get good union after 8 weeks. So these are pretty stable. Moving on to one that's close to my heart, the Jones fracture. Having had one, having my middle name also being Robert, from Sir Robert Jones. This is an acute fracture of zone 2 at the base of the fifth metatarsal, which is concerning because it's going to be one of our vascular watershed areas. So this is going to be at risk for and prone to non-union. Usually happens with a forefoot adduction. And so thinking about our pivoting sports, basketball, football, when patients or athletes are trying to cut and move, when their heel is lifted off the ground and they're really kind of pushing off the lateral aspect of that foot there. They might have some ecchymosis or edema, but they're definitely going to have tenderness along that fracture site. So comparing these to the avulsion fracture, you can see that this is moved distally along the shaft here, and we're into that zone 2. These can be then classified further by the TORG classification system. The type 1 is going to be more acute. That's going to be our top picture here. You can see there's no acute intramedullary sclerosis and minimal cortical hypertrophy. So there's no evidence of like chronic stress to this. Type 2 is going to be this bottom picture. We're starting to see some of the sclerosis involved around the black fracture line. And this is going to represent some delayed union. And then I don't have a picture for it, but type 3 is going to be our non-union. So this is going to be a wide fracture line. You're going to see periosteal new bone and radiolucency. And so that's important because it's going to affect our management. So the type 1s, we can attempt non-operative management for non-displaced fractures in our like more recreational athletes that are okay taking that 6 to 8 weeks off. But for your more elite athletes, people that aren't willing to risk not missing some of their sports for a while, you're going to consider the surgical referral. For the type 2s and the type 3s, you're definitely going to want to send those over to surgery for that intermedullary screw fixation or the ORIF with plate and screws. In zone 3 of the fifth metatarsal, this is going to be due to a stress fracture that's associated with the chronic microtrauma that we talked about earlier. Usually happens with patients that have the cavovarus deformity, and these are going to be at risk for non-union. You're going to want to make them non-weight bearing, and we're going to use the same TORG classification system. And if these are 2 to 3 on the TORG system, or if they're elite or competitive athletes, you're going to want to send them over to ortho to have a surgical consultation. Last but not least, the dancer's fracture, since we're in the fifth metatarsal. This is going to be the spiral or oblique fracture at that distal metatarsal, so further past zone 3. It's going to be common in ballet dancers. It usually occurs in their demi-point position here, and it presents with tenderness at the distal fifth metatarsal shaft. Here's our example on radiograph of what this would look like. You can see the oblique fracture through the metatarsal shaft. We can attempt non-operative management with symptomatic care versus non-weight bearing in a short leg cast. These usually take about 19 weeks to return to performance. Or if, again, we want to speed up that recovery time, or if they fail conservative treatment, where we can consider an operative management for this. So that is all I've got. That's my resources. Any questions?
So there's a whole lot to talk about with shoulder instability. You could talk about anterior instability, posterior instability, multidirectional instability. And then I think another big broad category is dividing shoulder instability with an intact glenoid versus shoulder instability with significant bone loss. So they're managed in a very different way. The best analogy I give to patients is, there's a lot of things we can do through a camera that can fix the lining of the shoulder or the soft tissue. But if you lose the glenoid bone, it's like a golf ball sitting on a broken golf tee, and there's no amount of physical therapy or bracing or other conservative management that it's ever going to keep that ball on the golf tee. So, so we have examples of like a 16-year-old young patient that comes in. We're going to ask them with these X-rays. They told you they dislocated the shoulder, and in the history, the things you want to know is it the first time you dislocated, or how many times has this happened? How did it happen? Was it something really traumatic, or did this happen like reaching across your bed and pulling on a sheet? What other what activities are you involved in? Is this a very high level competitive athlete, or is this just a young person with some simple day-to-day hobbies? Where are they in their season? Are they someone that desperately needs to finish out their season? Or is this something where we're headed into the off season and we have plenty of time to focus on rehab? What do they want to do with the shoulder in the future? Do they want to continue to play at a very high level, or is this just something that they're going to do in high school and then kind of phase out as time goes on and turn it into more of a recreational hobby? And then kind of going with that first one, how easily does this dislocate, or does it feel like it comes out just doing simple things around the house or in the gym? Does it constantly feel like it's trying to shift, or does this only happen when there's something really traumatic or violent? And does it affect both shoulders? And then lastly, have you any prior procedures? Because it certainly affects our management if this is someone that's already had some sort of attempted arthroscopic repair or other intervention, that it definitely changes our diagnostic pathway and our treatment pathway. So, what we've really learned about instability as we've started to study it more is that we overlooked a great deal of it for a long time. They've now shown that this instability, the bone loss starts at the very first dislocation, and it just gets worse over time. Even when you look at a first-time dislocator, you can start to see some blunting of the glenoid rim, maybe subcritical at that point, but each dislocation carries the risk of taking more bone with it. And we've really also shown a much higher rate of recurrence for non-operative treatment, especially in males at younger age. And one of the biggest risk factors for recurrence is bone loss, especially overlooked bone loss. Some of the studies, as we kind of follow them, show that we underestimate the risk of recurrence because if these patients stop participating in sports, whether they don't get caught in the future follow-up, they maybe stopped playing because they were concerned about the instability of their shoulder. So, all things that increase the risk would be high energy mechanisms, number of dislocations, how easy it is to dislocate, all those things are associated with more bone loss. Especially for contact athletes, the recurrence rate, it's a dramatic difference if there's a clear bony defect. Right? Like it's, look at the difference is 6.5%, 7% versus close to 90%. So we really need to be investigating, the severity of bone loss, especially in patients that have high risk factors for it. So, Burkhardt and DeBeer are some of the pioneers of arthroscopic surgery, especially management of instability. They're kind of commenting that we think so much of stability as a soft tissue operation, but despite being bone surgeons, we've kind of overlooked a lot of how important the glenoid bone is. So with acute injuries, there's often, if there is a large fragment, it's amenable to immediate fixation. Something like this very acute bony Bankart fragment. If that's addressed immediately, then we actually just repair it back as an internal fixation, either done arthroscopic, assisted, or open. If that goes on and it's not addressed, then by 6 months, a lot of these fragments have resorbed, and now you just have chronic attritional bone loss. So following these along by 15 months, you see a lot of erosive changes, and it's not even clear where the donor fragment was. And it kind of comes, I think that comes down just to Wolff's law that if you have bone that's not seeing any contact forces, then as far as the body's concerned, the bone doesn't need to be there, and it just gets resorbed. So the next part of our diagnosis, after talking to the patient, is a good physical exam. So there's a lot of maneuvers we can use to help evaluate the integrity of the labrum. Unfortunately, they're not all particularly sensitive or specific, so it's really putting everything together. Some of these tests, are really trying to just see, can you shift the humerus in any particular direction? My most straightforward one is just an apprehension test. So lay the patient on their back, bring them to the edge of the table, and start to slowly externally rotate the shoulder. If they have any hesitancy with that, or especially if they have pain, that would be a positive test. And if you then place your hand directly over the anterior humerus and provide a posteriorly directed force, if that alleviates their pain, that's even more confirmatory. Other tests look for more subtle pathology, especially for posterior instability, which is its whole separate talk. But often for these patients, if they have bone loss, the apprehension happens very early in that maneuver. So, as we start to look at some, scrutinizing our x-rays a little more clearly, every good series of x-rays should include a Grashy and an axillary. If you want to get very fancy, you can get these nice Bernageau views, but I think asking any of our techs here at DMC to get that, they would look at you like you had 6 eyes. But if you can get an actual en-face view of the glenoid, it's really impressive how much of the glenoid rim you can appreciate, and you get a sense for if there is any attritional bone loss. For me, I'm happy if I just get any sort of decent axillary, and at least it's obvious then, if there's a really discrete amount of bone loss, it tells me right away that I need to be concerned. And this is that Bernageau view, and you can even get comparison views and actually measure the whole diameter of the glenoid. And these are kind of nice things to know about that we just, in our clinical setting, we unfortunately can't get as often as I would like. So. So, in other cases, it's very obvious when you have severe glenoid bone loss or humeral bone loss. These massive Hill-Sachs lesions, things like that. So more often than not, we're going to go on to get advanced imaging. So that will start, in this case, we're looking at bone. Well, then a CT scan is going to be our best test. A lot of these patients will come are already with an MRI. And then you can appreciate if there is a bony defect, but unless you have a really high sensitivity MRI with really thin cuts, you can't really make any firm measurements about the glenoid rim or the glenoid tract. So that's where CT scans allow us to make really precise measurements and get a much better, understanding, especially if you can get a 3D reconstruction. So at this point, I think the gold standard for actually trying to measure how much glenoid bone loss you have, it's this picture on the left. And so when I order CAT scans for these patients, I have a whole essay attached to it of like how important it is to subtract the humerus and give me this view. So, because that's what I'm going to use as part of my clinical decision making and then later my surgical planning. Um, and there are so many ways to quantify the glenoid defect. And, you can do a best fit circle and make some measurements here. This is one of the ones that I like. I'm just looking at kind of how at the normal radius of the glenoid versus the defect side, and then making a percentage based on that. They did this big head-to-head comparison of all these different techniques, and when they were done, the one that performed the best is this one with this crazy calculation on the left side. And the nice thing is you don't have to do all of that math. What it really boils down to is if you take the normal radius of the glenoid, and then take the point of the maximal glenoid defect, the width at that point, and just divide the small number by the big number. And if you get a number that's very close to 1, great, there's no glenoid bone loss. And if you get a number that's very close to 0, then you have a profound amount of bone loss. And then where kind of the threshold for me is usually kind of in that 0.6 to 0.5 range. Like that's where, when you do the graph, you get somewhere between 15 and 20% of glenoid bone loss. So it's a really convoluted calculation that you don't have to do, but it's nice that this is a very simple comparison to do. Just D over R. That's it. So that's what I do in my office when I'm trying to get a measurement. And then again, for MRIs, if you have access to a three-dimensional MRI, that works just as well as a 3D CT, but I have never been able to get one of these here in Detroit, so it's not really clinically relevant. But at some of the big academic institutions, they have this, and then it saves a step. So, or if you really want to make your perfect evaluation, then you have to do it intraoperatively. But because the management is so distinct, this is really something where you should have a surgical plan prior to getting to the operating room. But you can make very precise measurements just with something like a calibrated probe. For this, it's just important to measure or to understand where the true center of the glenoid is, because the glenoid isn't a perfect circle. It's more of this kind of a little pear shape, and then make your measurements accordingly. Hill-Sachs lesions can also best evaluated with CT reconstruction. For these, what we're really trying to assess is this on track, which is a good thing, meaning that it tracks along the glenoid and never falls off of the track. So it moves smoothly, you don't get any catching. And then the opposite would be an off-track lesion or an engaging lesion where as the humerus rotates against the glenoid, it just keeps falling into this pothole. So essentially, the wider the Hill-Sachs defect is, the more problematic it is. And then the smaller the glenoid is the more, I guess, the smaller the Hill-Sachs can be to start causing problems. So it's measuring, you always have to measure both to get an assessment of is this actually engaging? And there's a whole lot of calculations for that too. I don't often do that in the clinic because it's very rarely going to impact my decision making. And for a lot of these, we'll talk about the remplissage in a bit, but in most cases, it's pretty clear whether they would benefit from it or not. So, if we do an isolated like soft tissue Bankart repair, so a labral repair and a capsular shift, we do decrease the contact area and we increase contact pressures. But if you take away any of the inferior glenoid, well, then you dramatically decrease the contact area and the contact pressures spike. So, that bone loss leads to it's much more symptomatic and it's just much more unstable for that very reason. And so this whole concept of the glenoid track, and they've done these really high tech mapping of humeral motion along the glenoid. So it gives us how we can make these measurements. They did this with 3D motion analysis and little probes put on the humerus. So I mean, it gave us a good understanding, but from a clinical standpoint, it's not anything that we're doing here in the office. So it just helps us know, from all this research that was done, what Hill-Sachs lesions do we need to be worried about. So, and there's another simple calculation for that glenoid tract. And then to get your Hill-Sachs interval, it's the measurement of the full width of the Hill-Sachs lesion along with the little bare area on the humerus. So it's putting those two things together. That gives you your whole Hill-Sachs interval, and then you can compare that to the glenoid tract. And then if the Hill-Sachs interval is greater than the glenoid tract number, then it's engaging or off track. Again, like these are real, I think, unnecessarily convoluted calculations, but for me, it just boils down to that if you do that calculation and you get even close to the Hill-Sachs interval equaling or being greater to the glenoid tract, that patient probably benefits from addressing the Hill-Sachs lesion with something like a remplissage. So, and if you really want to be precise with those measurements, then again, you do it arthroscopically. Now that gives it a much clearer assessment of, okay, great, there's my glenoid tract, there's my Hill-Sachs interval, and you do some simple kind of back of the napkin math right there. So, and there's a little kind of depiction of what it means by on track and off track. And so when it falls off track, and that's where it engages, and you get that kind of shark bite defect, or again, I describe it to patients like a pothole in their humerus. And so basically, the wider the pothole or the smaller the tire, the more likely it is that you end up engaging there. So, oh boy. And then here's an example of all those measurements. So you get the glenoid tract at 1.84. You measure that. The Hill-Sachs interval is 1.36. Hey, this one's on track. We don't have this paper, we don't have to worry about it. So then how do we treat all this? Like, we've gotten our diagnosis, we've gotten our imaging, we've got a good assessment of what's going on. Do we put them in a spica cast? Probably not. And most likely we're going to look at managing this in the operating room. So for subcritical bone loss, and that's a term that carries a lot of baggage because it's changed over the years, but we'll say, for our purposes, anything less than 15%, it's reasonable to attempt an arthroscopic labor repair and capsulorrhaphy. If there is a bone fragment, it can be incorporated into that, especially for acute instability cases. And so if you can get that fragment to incorporate, your success at achieving stability is much higher. If it's completely ignored, then you're probably going to end up with more bone loss again, especially if that's greater than 20% of the glenoid rim. And so we know that if there is any bone fragment at all, that there's going to be some degree of absorption in all shoulders. And so that's why even these small percentages are still at least worth understanding and documenting. And for those that have small bone fragments that incorporate, if it goes on to a union, well, then unsurprisingly, you have a lower rate of recurrence. So what is critical bone loss? Again, back in 2000, they had measured it at maybe 21%, 25%. Like, we really made the assumption that it had to be a profound amount of bone loss before it became problematic. And then as we've done more and more assessment of this and gotten better at getting 3D reconstructions, we've really seen that it's probably lower than 15%. Some papers just said as low as 13.5%. And that may be why when we compare modern arthroscopic labor repairs to the historic open labor repairs, that we're actually getting higher recurrence rates. And it's probably, I think, the easiest thing to blame it on is just an underappreciation for glenoid bone loss. So again, if you can incorporate the bony fragments, and then that functionally makes the amount of bone loss less severe. And then, but if they do lose that bone, and especially in more than 20-30%, then their instability rates significantly increase. And so once you get to 25 to 30%, if it's acute, then you fix it. I've got a couple of patients over the years where I've been able to get to them early, and then essentially just treat that free bone fragment the same way I would treat an allograft, and put parallel screws, and if those heal, they do great. Or if it's slightly smaller, then you can address it arthroscopically. But again, if you can achieve union, that is the ideal outcome. But if we can't get it united. If either the fragment is too comminuted, or more likely it's just attritional because they didn't get the correct initial treatment, then we are looking at a glenoid reconstruction. And the gold standard for this, certainly from our colleagues in Europe, is a open Latarjet. It's a procedure that has at least 30 years of high quality data from outstanding surgeons around the world. It's been proven time and time again to yield, good to excellent outcomes in, the vast majority of patients with a very low recurrence rate. But it does carry its own risk of complications. You are changing the shape of the glenoid permanently. You're changing their anatomy permanently. You're passing screws across the glenoid, and usually getting those retractors in the right place, you can cause any sort of iatrogenic cartilage injury can increase the risk of arthritis. If there's any malpositioning of the screws, they can become symptomatic. So it's, I think, a procedure that when it is done well, it's a fantastic procedure, but it takes a lot of skill to do it well. And if it's not, the complications can be pretty catastrophic. This paper doesn't even mention, the worst of the worst, which is a nerve injury. And those nerves can be the axillary nerve, the muscocutaneous nerve, or even the brachial plexus itself. So this is the kind of the modern algorithm for, how are we addressing these instability cases. So if it's less than 15%, or definitely less than 10%, ignore the bone loss, stop tissue. 15 to 25, somewhere in there. Look at some of the patient demands and what else is going on for them. If they're any sort of contact athlete, then we need to address the bone defect. If they're or if you have the bone fragment available, then you can fix it. And then for more significant bone loss, then it's either a Latarjet or some sort of allograft reconstruction. So one of the more modern procedures that started to become more popular as our techniques have improved is the use of a distal tibial allograft. When you map the distal tibia compared to the glenoid, the cartilage width and the angle of it actually matches very well, which is great because it's so much easier to get a tibial allograft compared to trying to get a glenoid allograft. You'd have to harvest an entire scapula. Those are not easy to obtain. So, this initially started with research from Matt Provencher in Colorado and a lot of work in the military population and athletes, but showing that an open distal tibial allograft achieved the exact same results as an open Latarjet, without having to take off the coracoid or doing that exposure. And then the next advancement beyond that is then doing this arthroscopically through a subscapular sparing approach. And so Ivan Wong is a surgeon out in Halifax, Nova Scotia, that has really pushed this. And I've had a chance to watch him operate, and went down and practiced these a few times. And so I've done about a half dozen of them now. Knock on wood, I've had good outcomes so far. And the recurrence rate in these patients is just as low as it is with the Latarjet. You see great improvements in their overall function. And then what I expect future data is going to show is a dramatically lower, incidence of iatrogenic cartilage damage, and certainly a much lower rate of nerve injury. So, and then for the Hill-Sachs, our management for that, again, depends on how bad is the glenoid defect and how large is the Hill-Sachs lesion. So in the first group, where you have a tiny Hill-Sachs lesion and minimal bone loss, you just ignore it. And the group where you have minimal bone loss but a pretty large Hill-Sachs and it is engaging or off track, then we incorporate the remplissage, which is the imbrication of the infraspinatus into the defect. And then as we start to get further and further down, and then we look at bony reconstructions. And then in the worst of the worst, you're either combining a arthroscopic distal allograft and a remplissage, or if for really catastrophic cases, it's even an open allograft of the glenoid as well as the bone grafting of the Hill-Sachs defect. That's a whole barrel of fish. So, the data for the remplissage so far seems to be excellent. That as we study it more and more, we're seeing much lower recurrence rates, especially in these patients with questionable degrees of bone loss. And this was a pretty small study back in 2016, but again, a 25% recurrence rate versus a 5% recurrence rate is an outstanding improvement. And but we do see a little bit of loss of external rotation. And for the vast majority of people, that's not clinically relevant. But I have a little bit of hesitancy in adding a remplissage to like a high level tennis player or an overhead athlete, someone that really needs every last bit of abduction and external rotation. But for, again, the majority of folks, the remplissage doesn't carry any meaningful loss of function. And then, and this is, like I said, some of these, dramatic, disaster cases. So especially like patients with uncontrolled seizure disorders, or other, or connective tissue disorders that lead to just completely uncontrolled instability. We look at, rotational osteotomies or resurfacing arthroplasties, again, or osteochondral allografts. Like there's always some way to manage these really extreme cases, but thankfully these are few and far between, even at a big academic center. So a very common story that I would see in my office would be, 17-year-old high school wrestler. He's had multiple dislocations. Uh, he's always been able to either pop it back in himself and it hurts for a few days and then he keeps wrestling. It's now gotten to the point though where he's not competitive. So by the time I get to him, he's already developed, fairly severe bone loss. The bone fragment is nowhere to be found. It's completely attritional. But thankfully, he doesn't have, while he has a Hill-Sachs, it's not particularly severe. So this is someone that is amenable to an arthroscopic distal tibial allograft or a Latarjet, where, if you can get nice long parallel cannulated screws, that graft incorporates and it looks pretty much like native bone. Again, I think why these screws look so long is I suspect that it's the portion of the graft resorbed. It's functionally shortens or decreases the width of that glenoid. So, but knock on wood, they don't bother him. So we're going to leave those alone. So, yeah. So that's a pretty reasonable summary of how we tackle glenoid bone loss.
Thanks, Chase. Have you, as far as just the logistics of getting these cases scheduled and authorized, from insurance, are you any difficulty when you're talking about these tibial allografts? I ask because I know Sean Bach has had certainly some challenges and uh, getting pre-auth from insurances. The case expense for the hospital is obviously quite significant and whatnot.
Yeah, thankfully, I haven't run into a lot of insurance approval issues. It is more from the hospital side, just trying to accept the cost of the graft. Where it's worked for me is just an industry relationship where they're able to obtain the graft as almost like part of the approval of the equipment required for the procedure. So that decreases some of the cost for that. But more, it's just I think the timing of these because there is data showing that a fresh allograft yields better outcomes than frozen. So I try to order the graft with like a 3 to 5 day lead time so that it's viable on the day of surgery. But so that means the case needs to be approved and on the board and everything has to be ready to go. And then God forbid the patient like gets sick or can't come in that day. That's a big wasted expenditure. So, but it is from a billing standpoint, it's a very similar code to the Latarjet. As long as you document the severity of glenoid bone loss, I haven't had any issues getting it approved by insurance.
What's the status with, I know that for a while, we're using iliac crest, and I don't hear anybody talking about iliac crest anymore. It's all about the distal tibial allograft.
Yeah, I think it's just no one likes harvesting the iliac crest, and uh, I mean it does function very well as an autograft, but there's always the issues of pain at the harvest site or complications related to that. Um, and it's so much easier to just have the allograft ready to go. And I mean, the measurements are straightforward. I mean, it takes me maybe 10 minutes to prep the allograft on the back table compared to, at least a half hour trying to get a good sized iliac crest autograft.
Cool. Thanks, Jason. Also to Dr. Arslan, thank you both. Very nice lectures this evening. Matt, are you up next?
think we're done for the day.
Yeah, I think that was it. Yeah.
Okay.
Yep.
Cool. All right.
Thank you.
Thank you.
Have a good night, everyone.
Have a good evening.